Hi, I'm Michael Camilleri. I'm a professor of medicine and physiology and pharmacology at Mayo Clinic in Rochester, Minnesota.
So could you give us a brief background on how you got into medicine and also specifically the field of gastroenterology?
Yeah, I was always interested in the field of medicine from when I was a kid. Actually, growing up in Malta, I often watched Dr. Kildare and Dr. Marcus Welby on television. It was black and white at the time, and I really was attracted to the way in which they approached patients. And of course, this was artificial, if you wish, because it was a series. But I was attracted to the way in which patients were dealt with, and also eventually, when I was a medical student, I became very interested in the way in which the gastrointestinal tract function, particularly nutrient absorption, and what goes on in the gastrointestinal tract with disease states. So that's how I started into medicine, and that's how I eventually picked gastroenterology as a specialty.
What would you tell someone who's considering gastroenterology today?
Go for it. I love this specialty. There's so much good you can do for patients, for society. You can choose a diverse interests, whether it's liver disease, nutrition, obesity, gastroenterology itself. You can become an expert endoscopist. You can perform procedures that will help to deal with disease states that affect the gastrointestinal tract. So it's such an impactful specialty. It has meant so much to me. It has brought me so much pleasure being able to contribute to the care of patients and hopefully to advance the discipline of gastroenterology.
What motivated you to join the AGA governing board and eventually become president?
So, what motivated me to join the leadership within the AGA, and subsequently, I was fortunate enough to be selected to become the president. I was very impressed by several people that I observed during AGA meetings. I'll never forget the leadership qualities of former presidents. And the ones that I will never forget are Dr. Tachi Amada, Dr. Dan Podolsky, and Dr. Martin Brotman. And each one of them had different impacts in the way I looked at leaders. Um, so I liked the way in which they brought consensus. They attracted young people. They mentored people like myself to take up positions and committees at the AGA. Subsequently, become an associate editor and an editor for clinical gastroenterology and hepatology. And I just admired them and thought that I'd love to see whether I can also contribute, and I was fortunate enough to be selected and ultimately to become president.
What do you recollect from your time as president?
I recollect some things with great pride, actually. It was a time when the American Board of Internal Medicine had set down some rules regarding maintenance of certification. And one of the things that I really cherish is the fact that the leaders and the organizations they represented, the leaders of the American Gastroenterological Association, American College of Gastroenterology, Association of Liver Disease, the AASLD, as well as the ACG, the American College of Gastroenterology, we all came together in order to speak with one voice regarding our perspective of maintenance of certification. And over the years, the ACG, ASGE, AASLD, AGA, we've stuck it together and we have been able to have an impact. It's taken some years, but it has happened to help make maintenance of certification much more practical, much more relevant, and less of a less of an onus on the people's time and activity, as well as the expense. So that's one of the factors. I'm also very proud that we started the clinical practice updates as a means to complement the AGA guidelines, as well as starting a serious initiative on bringing gastroenterologists to understand opportunities to care for patients with obesity, whether it's medications, which have really advanced in the last 5 to 10 years, or procedures with endoscopy, or even surgical procedures. So those are three things that I really remember we worked on, and I felt very positive about the outcomes.
What impact did leading AGA have on you personally?
I've always felt that the impact of the AGA was to give me an academic home away from my home institution. And as my academic home away from home, I have met such incredible people. I've learned so much. I've been mentored, as I said, by people who are not at my institution, but I've also met colleagues and peers who have helped me understand the illnesses that I'm interested in working on, as well as um, inspiring me to pursue further questions which would not have come about if I hadn't been at the poster and somebody came along and gave me a question I couldn't answer, and that fostered the next series of research activities or clinical practice advances.
Can you share your thoughts on where AGA is today?
Where is the AGA today? AGA, like many other academic organizations, I think is at a crossroads. I think there's so much happening in society that makes it rather difficult to know exactly where academic organizations should be going. But I often take the opportunity to say, ultimately, our goal is still the same, and that is to understand illness, to understand the needs of our patients, to really understand what are those societal or public health problems that we need to address. And I often think about three particular types of problems. Problems related to nutrition, whether it's malnutrition with bowel dysfunction or inflammatory diseases causing malnutrition. The second, as I said before, obesity is a major uh, challenge from a public health perspective because of all of the complications, cardiovascular, cerebrovascular, diabetes, endocrinology, etc., as well as the musculoskeletal problems that happen with a greater prevalence in obesity. So we are, I think, at the threshold where the AGA can really play a leadership role in the management of patients who come to see us in the clinic, sometimes with unrelated diseases like gallstones. We need to ask ourselves, what are we doing for the patient's elevated body mass index, not just thinking about referring the patient for a laparoscopic cholecystectomy. And then the final point, so having said there were 3 points, let me just remind you, it's nutrition and malnutrition, obesity, and the third is cost-effective ways to identify and prevent cancer. And of course, the predominant one in our specialty is colorectal cancer, but let's also remember other cancers for which the mortality is so high, including pancreatic cancer and gastric cancer. We're on the threshold of being able to apply augmented intelligence. I rather prefer augmented to artificial intelligence and machine learning and other endoscopic techniques and methodologies that will allow us to be more effective in identifying and hopefully treating early cancers in those diverse organs.
Anything else that you would like to share that I didn't cover?
I don't think there's anything else other than to reiterate the tremendous opportunities for young people to enter the field of gastroenterology because of the breadth of expertise that they can develop and the major impact that they could have on so many patients. And of course, to remember that the AGA is one's academic home away from home.